Hey, how you
Okay.
doing?
I'll sit by you.
Come on.
This is
Come
one
on
of
close.
the witnesses in opposition? Okay. Yes, go ahead.
Thank you. Madam Chair and committee members, thank you for the opportunity to testify today. I'm Karen Karp from Sonoma and a certified registered nurse anesthetist, which is abbreviated CRNA. I'm here today representing the California Association of Nurse Anesthetists, which has served rural and critical access facilities in Northern California for a very long time. CANA passionately shares the author's commitment to increasing access to quality health care in the state. However, we respectfully must oppose the approach of AB 890, which will do nothing to increase access to quality anesthesia care and yet will increase health care costs and may compromise patient safety. Nurse anesthetists have been providing safe, full-service, high-quality, and cost-effective anesthesia care for over 150 years. CRNAs are required to earn a 4-year bachelor's degree in nursing and practice an average of 3 years in a critical care setting, such as medical and surgical intensive care units, before being accepted into a master's or doctoral nurse anesthesia program. CRNAs are able to administer all aspects of anesthesia autonomously, from pain management to trauma stabilization services, with no mandatory requirement for physician supervision in any setting. The safety and efficacy of CRNAs has been documented by multiple published research studies, the most recent in 2014. In 2009, California became one of 17 states exempted from the federal CMS requirement for supervision of nurse anesthetists in order for hospitals to receive Medicare reimbursement. The California Society of Anesthesiologists sued the state unsuccessfully up to the Supreme Court over the opt-out, which was defended by then Attorney General Jerry Brown. The opt-out was upheld unanimously, and since that time, CRNAs have been able to provide these critical services autonomously in rural and underserved areas, and this has greatly reduced the barriers to providing that care. There are now 7 nurse anesthesia programs in the state of California, and a recent survey shows that up to 40% of nurse anesthesia graduates must leave the state to find their first job. This would seem to indicate that there is no shortfall of nurse anesthesia providers. CRNAs practice autonomously and alongside our anesthesiologist colleagues in 82% of California counties providing medical services, and they are sole providers of anesthesia in 7 rural counties. In comparison, AAs or anesthesiologist assistants have less training and require close on-site supervision. And my colleague from California Nurses Association will go over this in detail. The role of the anesthesiologist assistant is to assist the anesthesiologist. This can only happen when an anesthesiologist is on-site and available.
I'm just concerned that the other witnesses will have no time at all unless you wrap up. So
Thank you.
There's 4 minutes left.
Thank you.
Thank you.
Okay. The Centers for Medicare and Medicaid Services recognizes that AAs are not interchangeable with CRNAs and mandate medical direction by an anesthesiologist. We respectfully ask for your no vote on AB 890. Thank you.
Madam Chair, Member Stephanie Roberson on behalf of the California Nurses Association, respectfully in opposition to AB 890. Oftentimes in BNP committee, we weigh out the public policy and patient safety considerations to decide whether a scope of practice change is warranted or if autonomy is appropriate. In this proposal before you, we are considering the possibility of introducing a new, albeit duplicative and limited provider called the anesthesiologist assistant, or AA. The role of the AA is to assist the anesthesiologist. AAs are not educated to serve as PAs, and there are clear limitations concerning where AAs may assist in the administration of anesthetics and under what conditions. AAs are not autonomous providers, so to think that this bill can be a substitute to the CRNA, who are educated to exercise independent judgment and practice autonomously. This bill doesn't solve the problem. AAs are not required to have any prior healthcare education experience before they begin their training program. Unlike the CRNA, they are required to obtain a substantial amount of experience even prior to the anesthetic training program, and is laid out by my colleague from CANA. Respectfully, this bill does not require AAs to have a California license and does not set up appropriate oversight by a state agency. This bill does not resolve the purported issues of access as stated previously. Not sure if stated previously, but definitely we saw that in the analysis. AAs cannot practice autonomously like CRNAs. This bill lacks public protection. CRNAs are the answer and have been serving the needs of Californians for many years. Sponsors have also stated that this bill resolves the nursing shortage. There is no shortage of CRNAs, and according to the Bureau of Labor Statistics, CRNAs projected job growth between 2012 to 2022 will increase by 25%, higher than any other advanced practice RNs, though all classifications are on the rise, and Ps are the next. So with this, we stand in opposition to 890. Thank you so much.
All right, and there are 2 minutes left for witnesses to speak other than just stating their name and organization.
Okay, Madam Chair and members, Roxanne Gould representing the American Nurses Association of California. I seem to follow Stephanie around saying me too, but we're in complete agreement with CNA on this bill. We believe the 40,000 CRNAs that are required to have a great deal of experience in education are far better qualified to do this than the 1,800 that are not required to have any education prior to entering the educational system.
Okay.
Charles Griffiths, PhD, certified registered nurse anesthetist from Los Angeles, president of the board of the California Association of Nurse Anesthetists, and practicing at the Veterans Administration Hospital in West LA. Though we agree with and admire the author's intent to increase access to care, thank you. We respectfully disagree with this approach. California has sufficient anesthesia providers, according to an analysis that we've looked at. It has a maldistribution of these providers. Anesthesiologist assistants are unable to increase access to care in the medically underserved areas since they require the presence of an expensive medical specialist physician anesthesiologist, which would increase the cost of care and might even cause some of these critical access hospitals to have to close their doors. So we oppose AB 890.
Thank you. If you could state your name and organization.
Good morning. I'm Elizabeth Wong with the California Association of Nurse Anesthetists, and I'll be very brief. I work currently at Desert Regional Medical Center in Palm Springs, and I strongly oppose AB 890.
Thank you. Just name and organization. Thank you.
Hi, good morning. My name is Bob Hendricks. I'm the Executive Director for the California State Retirees, representing over 34,000 members who served this great state as employees and have since retired. As this bill is currently written, one would surmise that this is predominantly a bill that are anesthesiologists versus nurses. We see this bill a little bit differently. We see this bill about the patients. And in particular, the bill also had talked to the fact that we have a large baby boomer population, et cetera. We see that as a reason why this bill should be opposed, in that as we age, we know that those are the individuals that require more care. And they are also the greatest individuals at greater risk during surgical events.
All right. I'm going to have to ask you to conclude. Thank you.
So we would just recommend a no vote. Thank you.
Thank you. Please just state your name and organization and your opposition. Thanks.
My name is Brian Toon. I'm the Program Director of the National University Nurse Anesthesia Program and the Chief Operating Officer of Omni Anesthesia Incorporated, and I oppose this.
Thank you.
Hello, my name is Dr. Haik Topajikian, CRNA. I work at Kaiser Los Angeles Medical Center, and I oppose this bill.
My name is John Wilton. I'm a tax-paying resident of Mount Shasta. I work at Mercy Mount Shasta, CRNA, provide anesthesia services there, and I oppose this bill.
Hello, my name is Natalie Brown. I'm from Orange County, California, and I oppose AB 890. Thank you.
Michael Young, California Labor Federation, in opposition.
My name is Florence Zilko from Temecula, California, and I oppose Bill 890.
Hi, my name is Binja Casey, and I'm from Fresno, California, and I oppose AB 890.
Hello, my name is Erica Islan from Los Angeles, California, and I oppose AB 890.
Hello, my name is Jonathan Gardner. I'm a student registered nurse anesthetist in Fresno, California, and I oppose this bill.
Eric Robles, United Nurses Associations of California, and we oppose.
Mary Davis from Sonoma, California, a concerned citizen, and I strongly oppose this bill.
Good morning. My name is Chris Florentino, National University Fresno, Sacramento, and reside in Sacramento, California. Strongly oppose AB 890.
My name is Titus De La Cruz from Los Angeles, and I oppose this bill.
Hello, my name is Linda Walsh, and I'm the president of the California Nurse Midwives Association, and our organization strongly opposes this bill.
My name is Tony Drew, SRNA in Fresno, California, and I oppose this bill.
My name is An Ching. I'm from Los Angeles, and I oppose this bill.
Good morning. My name is Ed Matthews, Assistant Chief Nurse Anesthetist at Kaiser Vallejo Vacaville from Benicia, California, and I oppose this bill.
Good morning. My name is Evan Schoen, practicing nurse anesthetist at San Francisco VA Medical Center, also for Kaiser Permanente Napa Solano area, also the core simulation team assistant to Samuel Merritt University. I strongly oppose this bill.
Good morning. I'm Kim Westbrook. I'm from Vacaville, California. I'm a nurse anesthetist, and I oppose this bill.
Good morning. My name is Matthew Struthers from Fresno, California, and I oppose this bill.
Morning. I'm Trisha Ucci, one of the practicing CRNAs at UC Davis Medical Center, and I oppose this bill. Thank you.
Good morning. I'm Kevin Bleasdale. I'm a CRNA at Vacaville Vallejo Medical Centers, and I strongly oppose AB 890.
Hi, I'm Annalai Mark, a student registered nurse anesthetist, and I oppose this bill.
My name is Lydia Bailey. I'm a student registered nurse anesthetist and representative for the class of 2015 for Samuel Merritt, and I oppose this bill.
My name is Kristen Dill. I'm a student registered nurse anesthetist, and I oppose this bill.
Hi, my name is Amanda Dennis. I'm a CRNA at Kaiser Sacramento, and I strongly oppose this bill. Thank you.
Good morning. My name is Joseph Janakis. I'm a resident of Dublin, California, and I am a nurse anesthetist. I'm also the associate director of the Samuel Merritt University program, and I strongly oppose this bill. Thank you for your time.
Good morning. My name is Chris Otto, assistant chief nurse anesthetist, Kaiser Sacramento, and I oppose this bill. Thank you.
I'm Catherine Thiers. I'm a CRNA, and I strongly oppose this bill.
I'm Luisa Moya from El Dorado Hills, California. I work for Kaiser Permanente, and I do oppose this bill. Thank you.
My name is Elisa Cardell Truman, and I am a CRNA in Sacramento, California, as well as in Placerville, California, and I oppose this bill.
Good morning, Alice Moore, CRNA from Kaiser South Sacramento, and I oppose this bill. Thank you.
Good morning, Rebecca Orlino from UC Davis Medical Center, and practicing CRNA, and I oppose this bill.
My name is Jennifer Lindberg. I'm a practicing CRNA from Kaiser South Sacramento, and I oppose this bill.
Good morning. My name is Lisa Daniel, practicing CRNA at Kaiser South Sacramento and Sutter Memorial Hospital, and I oppose this bill.
Good morning. I'm Myra Morales. I'm a staff nurse anesthetist at Kaiser South Sacramento, and I oppose this bill. Thank you.
Thank you. Questions from committee? Mr. Dodd.
Yeah, I don't know. Mr. Ridley talked. I appreciate this coming up, and I'm wondering if maybe we should have the experts up there. But I guess I've got a couple things.
I'll try to pitch it
Yeah,
since
ask
it's
your
my
question.
bill first.
We'll call them up.
Thank you. You know, I represent mostly rural districts, and one of the things I'm really concerned about is this really going to expand access to care? I'm concerned that this bill could, in rural communities, reduce the access to care, and I'm just kind of interested, probably on both sides, of how that plays out.
The bill sponsor can come sit at the table.
I'll get to it by starting with this. The state has an entity, OSHPOD. I can't remember what is the Office of. You know what I mean, OSHPOD, and they have a research unit that analyzes medical service and the quality of care and the like. Typically, they do a report that says whether or not you have a shortage in workforce in order to meet the needed demand for particular medical care. They had yet to do a report on anesthesiology. However, they referred us on multiple occasions to a RAND study that indicated that there was a shortage in anesthesiology services. there were comments from some of the opponents of the bill about particular parts of the healthcare profession, particularly nursing, that are growth professions. However, our observation and the reason I accepted the bill was because I noticed in visiting surgical centers and in visiting places where we see more and more surgical services delivered, that we had an aging workforce, that the pockets that were not being served were not fully served by the certified nursing professionals who are currently, I think, more in the rural areas, frankly, and some of the medically underserved areas, and we still needed to invest in the anesthesiology workforce. This is an attempt to do so. With respect to those who are opposed, I did not believe that it will reduce care in rural areas. I think it will, frankly, help providers, particularly in urban areas, help staff up because they have a shortage now. That is an empirical fact. That is 2 RAND studies over the last 4 years that indicate as much. So we have a shortage currently.
Okay, through the chair.
Yes.
I am not opposed to this bill. No. I am firmly on the fence on this one because I'm trying to figure out how it increases access to care if the anesthesiologist has to be there supervising.
We'll let the anesthesiologist
they're losing
answer that.
personnel too.
Well, briefly.
Yes. First of all, I mean, this is a workforce shortage issue, and actually, when you overlay the places that anesthesiologists live and nurse anesthetists live, which we have a graph of, which should be part of your packet. If not, we'll get to. They actually live in exactly the same places. There actually is no real disparity, and this is a general workforce issue. And as you add more people into the workforce, what you will find is that people will tend to migrate out to other areas. And I'd like to defer to Dr. Nielsen because she has actually, as an anesthesiologist assistant, worked in rural areas. So I'll let her comment on that as well.
Yeah, I mean, as an anesthesiologist assistant, I worked in rural Macon, Georgia. That's very rural, if anybody's been there. Also in Bennington,
Let me redirect
Vermont.
the question to I think what we're trying to get at, which is how does it save time for an anesthesiologist to have an assistant? How is this something that becomes more productive?
As a physician, one physician can supervise up to 4 anesthesiologist assistants. That allows and frees up the anesthesiologist to handle emergencies and to be more involved in the entire spectrum of that patient care so that they can handle emergencies, they can do the preoperative evaluations, they can be working on ensuring that anything happens, and then when anything does happen, that physician is available to help. When bad things happen in the operating room, you need more than one pair of trained hands. You know, if a surgeon hits something that's large that bleeds all of a sudden, you need help. And that's why the team-based approach has been shown to decrease complications by up to 20%, to be 20% safer.
I think
and
also,
that's why that system works.
for clarification, supervision does not mean you're standing next to each other.
You are during key parts of the procedure.
But in terms of like the other functions you described,
correct.
If there's 4 of them, you can't be in 4 places at once.
No,
right.
Not that I know.
Okay. Does that answer the question?
Yeah, I think it does. I guess the other thing is it's just that, got to be said is obviously the anesthesiologist is getting a fee for each one of these 4 people that are working under him. And what I'm not interested in doing is undermining the anesthesiologist,
the nurse,
certified nurse, anesthesiologist industry from the standpoint is they are providing a service now. It is working. Why is this necessary to put on? And
it's necessary because there's a workforce shortage, because we need more nurse anesthetists. So we're not saying don't hire more nurse anesthetists. AAs will not replace nurse anesthetists. And anesthesia assistants will work alongside nurse anesthetists in the physician-led, patient-centered care team model. But we need more nurse anesthetists, we need more physicians, we need more anesthesiologist assistants. And to leave this type of care provider on the table, we think is not a good idea for the patients of California. I mean, when we survey patients, every survey shows that patients want...
That's okay. Ms. Eggman?
Thank you. And thank you for bringing this forward today. And I'll just start out by saying I won't be supporting this today. I heard a lot of opposition from my district. And just some points. I don't think the RAND study focused specifically on California, and I think what you're talking about is California specific. And the RAND study is global, so maybe other folks don't have a shortage, but I don't think there's any evidence that we do. And just to say, So there's currently, as far as I know, no real academic program set up in the state of California, nor is there a California certificate program or licensure program for AAs in the state of California. So basically, we'll be importing people from other states under a national certificate. And as a former educator and someone who's a licensed clinical social worker in the state of California, I can certainly tell you that the licensure regulations in California are far superior than some kind of national certificate. And then I don't think we have any regulations in place that say how many AAs would work under one physician. You kind of scared me when you said, well, we can have 4 rooms going on at once with one physician somewhere and then 4 AAs working. And so there's no structure set up yet to define what that kind of supervision is, nor any kind of certificate program yet in California. So with regret, I'll be voting no on this bill today for the stated reasons. But thanks for trying to bring it forward.
Yes, please respond.
Well, I would say that RAND is based in Southern California. I think it's based in Santa Monica. And since they're impacted by the healthcare system, they always look, when they do their reports, at the entirety of the country, including California. The national, accepting the current certification is a form of reciprocity. We'd hope to build a regulatory scheme. There's a critical part of the workforce that we can get more people to work in the healthcare delivery system. If we allow this is a statutory prohibition that is long overdue to be enhanced, reformed, and modernized. We're in the 21st century. Let's act like it. And that's why we have this bill forward.
All right. Any other questions? Mr. Wood.
Yeah, I've got a couple of questions. Currently, as an anesthesiologist, if you're in surgery, you are with the current formula. You have to be there with the patient. Period. Correct.
Correct.
Okay. And I've got multiple questions. I've kind of got a weird thought process here, so try to follow me.
Yeah,
don't go there. Okay. The anesthesiologist assistants are not meant to replace CRNAs.
No.
Okay. I think that's a really important thing here. Is it possible that at some point CRNAs could employ or work with anesthesiologist assistants?
In theory.
It's unlikely based on their training. The way, and I'll defer to Allison Nielsen, but anesthesiologist assistants are trained to work with physicians as physician extenders, and that's part of their training, and that's how they are licensed, and that's how they work. Anesthesiologist assistants are analogous to a physician. They are to anesthesiologists what a physician assistant is to most medical specialties.
You're talking about another scope of practice, evolution.
Okay, so. And that was just a question. So,
would you like to carry the bill? Just to start there.
All right, we got to keep it moving.
A couple more questions. Thank you. And first of all, I want to give kudos to the CRNAs. In 2 of the counties I represent, there are no MD anesthesiologists. In Del Norte County, there is 1 CRNA. In Trinity County, there is 1 CRNA. There are no MD anesthesiologists. So my kudos to you for being there. But it also points out a challenge in providers. I'd love to see that we get MDs, and I would love to see that we figure out a way to get MDs there as well. I can see, quite honestly, I can see the efficiency through supervision. And I go back to, while it is not a direct relationship to what you're doing as an anesthesiologist, it is somewhat comparable. Oral surgeons employ dental assistants that are often they are surgical assistants that are trained to work with them, essentially extenders. Oral surgeons administer general anesthesia to patients, and they are allowed to have an assistant work with them that allows them to be able to begin anesthesia on a second patient in the same office, and allows this person to monitor. So I can see by extension what the anesthesia assistant can do for efficiency in the operating room, because it gives you the opportunity to supervise multiple surgery suites, therefore being able to accomplish more surgeries in a given day. So I can see there would be a significant savings there. So I think that some of these things can continue to be worked on. I do have a little bit of concern about the national certificate and the fact that we don't have a program here to certify here. But and I do believe that there is a shortage of need. I think when you look at the number of anesthesia providers in the state and the number of amount of surgeries going on, I know that there are challenges with that because I see it in my own communities. So I am prepared to support the bill at this point because I think it is a step forward. I really don't think it will increase costs. I actually think it has potential to decrease costs. And I think it has the potential to increase access. So I will be prepared to move forward today. Thank you.
Any other comments or questions by committee members? Mr. Dodd. Okay.
I'm sorry, Madam Chair. I'd like the other side to talk about the access to care issue. That's the one thing that I still have some reservations on.
Please.
Really quickly, and I'll let my colleagues speak to the other issue. To your question about you don't think that this bill it will substitute CRNAs, there's nothing in the language, and we've worked on these issues for many years where you'll see specific language that says this category of provider is not used to supplant another provider. That's not in the bill. So theoretically, these providers could be used to supplant CRNAs easily. On the issue of costs, cheaper costs maybe for hospitals, they may employ these individuals at a cheaper cost because they don't have the rigorous training and education that CRNAs do. If you look at the salaries, and appropriately so, they should be compensated as such. But we do definitely see this bill if it moves forward. Now, I'm not saying it's the Assembly member's intent, but we do see this as a substitute or a supplantation to CRNAs. There's no language in the bill that explicitly states that that's not so.
Would you like to comment on the same issue?
On the access to care. On the access to care issue. I just wanted to point out to the committee that nurse anesthetists can function and work and practice in any position that would be open to an anesthesiologist assistant, but anesthesiologist assistants cannot function in roles where CRNAs work autonomously. And so they really cannot improve access. I'd also like to just reiterate that up to 40% of our nurse anesthesia graduates from California cannot find jobs in California, and that the RAND study, when you look at the statistics, it actually shows an increasing anesthesia workforce up to 2022. And this mirrors what we're seeing in our nurse anesthesia program graduates. They cannot find jobs here.
Okay, Mr. Bloom.
I'm going to be supporting the bill today for many of the reasons that Assemblymember Wood identified, but I'm going to keep a close eye on it and invite advocates to continue meeting with me and reserve judgment for my vote on the floor. I do believe that there's a national shortage, and how that manifests itself in California, I think, is somewhat of an open question right now. I don't think, with all due respect to the author, that RAND would be providing some weight to our local communities in their study, because that would really invalidate their results if they were to tilt it in that way. So I appreciate the shout out to Santa Monica and the great work that RAND does, but I do think that that's likely the case. I believe very strongly, having heard from a lot of healthcare providers, including those that I know very close and personally, that we are going to be seeing an explosion of surgical interventions. This is where technology is leading us, and for purposes of diagnostic and otherwise, this is where healthcare is going, and it's to the benefit of all of us that we make certain that those services are able to be provided in a cost-effective and efficient and safe manner. So for today, I'm supporting the bill and look forward to hearing more about it.
Thank you. I think that you've heard clearly on the issue of there's no desire to supplant what everyone on the committee, I'm sure, believes to be highly qualified and very necessary nurse anesthetists that are making a tremendous difference within our communities. Also, I think there's an unresolved issue with the data in terms of that I think it would be very beneficial for you to dig deeper into that as if the bill does move forward, and I think that would help in the future committees that you're in. With that, I don't see other comments. I think that there's some work that you need to do on this, and we'll see how it goes and if it goes. Thanks.
Thank you.
We'll have a motion, I believe, long ago, and a second?
We had a second.
Okay.
Motion is to pass as amended to appropriations. Bonilla.
Aye.
Bonilla, aye. Jones. Baker. Bloom.
Aye.
Bloom, aye. Burke. Chang. Chang, aye. Dodd. Eggman. Eggman, no. Gatto. Gatto, no. Holden. Mullen. Mullen, aye. Ting. Wilk. Wilk, aye. Wood. Wood, aye.
6-2, the measure's on call.
Thank you. Thank you, Madam Chair.
Thank you.